Thanks, Jack, and thanks to all of you for being here and spending your Saturday with us. This is a great opportunity, as Tafik said earlier, for us to learn as well as to teach a little bit. I'm going to talk about immunotherapy in patients with lung cancer. What I'm going to start with is a little bit about why immunotherapy might work, what the concept is. Then I'm going to take you through the data about general patients with lung cancer who've been treated and why there's excitement around use of immunotherapy. And then I'm going to talk specifically about what we know predicts which patients should benefit and how the Venn diagram of all that overlaps with patients who have the mutations that this conference is focused on. So just to hit a few bullet points of the key underlying ideas here. One is that we think that a tumor shouldn't exist in people, and that one of the ways it exists in people is because there's been tolerance. The immune system has developed tolerance to that, and that is because there's persistent presence of the tumor, and that leads to something called exhaustion or tolerance by T cells. And so the T cells that otherwise would take care of a cancer just can't do it. One of the markers on a cell is the PD1, and that's a receptor on tumor cells or more commonly virus-infected cells that makes T cells think that they shouldn't attack that cell. And maybe if you block that interaction between PD1 and PDL1, you can restore tumor-specific T cell function and actually use the immune system to target the cancer, to eliminate the cancer. That's the idea. So this is the cast of characters, if you will. Nivolumab, if you watch TV, you've seen a 90-second ad for Nivolumab in the last couple weeks. The trade name for that is Opdivo, and that targets the PD1 molecule. Pembrolizumab, Jack alluded to earlier, this drug was approved yesterday for the treatment of patients with lung cancer. The trade name for that is Keytruda. Another one that's a little further down the road is atezolizumab, and that has not yet developed a trade name as far as I know, and that targets the PDL1 molecule, kind of the opposite side of this interaction. I'll show you some cartoons in a second. And then the last one is Ipilimumab. This drug's actually been around for a long time. It's been approved for melanoma for a number of years. This week we did see the approval in melanoma of the combination of Ipilimumab along with Nivolumab. So that's certainly where we're going in the future, is combinations of therapies. So this is what people refer to as the immunologic synapse, or the interaction between virus-infected cells or tumors and the T cells. So the T cells in green on the right, the tumor is in pink on the left. And these little figures here are designed to represent cell receptors and their interactions. And you see on the tumor-infected cell, or I'm sorry, the tumor/infected cell, there's PDL1. There's also PDL2, we're not going to talk about that. And then on the T cell is the PD1. And this interaction between the two of those molecules leads to the T cell being tolerant of the tumor and not taking it away and not killing it like it should. But the idea is if you can block that interaction, then that you won't have that tolerance there. This is a similar slide. I think it probably doesn't add enough to the conversation to go through it, except to say that there are a lot of other receptors, co-receptors, and those interactions are important as well. So probably the best data we have to suggest that immunotherapy is useful for patients with lung cancer are two randomized trials that had essentially the same design. And this is the design. It took patients who had recurrent or metastatic lung cancer, one prior therapy, platinum-based doublets. All the patients who enrolled had that. And then patients were randomized to another FDA-approved, quote, second-line, unquote, therapy called docetaxel. So many of you know Taxotere, docetaxel. It's a commonly used chemotherapy. And the other half of patients were randomized to immunotherapy with Nivolumab. There were two trials that were exactly the same in the design. One was for patients with squamous cell lung cancer. One was for patients with non-squamous cell lung cancer. And non-squamous, of course, includes adenocarcinoma. These trials had pretty similar results, and I have a table here showing the results of this. So these are the arms for docetaxel and nivolumab and the two subgroups. So for the endpoint of overall survival, treatment with nivolumab led to longer median overall survival. I'll show you the pictures in a second because that's sometimes helpful. For patients with non-squamous cell lung cancer, similarly, there's improvement in overall survival. Progression-free survival differences for both these aren't so dramatic. When I show you the pictures, we can talk about that. And then I think probably, to me, the more resounding difference is in response rate, so chance that the tumors significantly shrink. And for patients with squamous cell lung cancer who got docetaxel, the response rate was 9%. And that's exactly what we expected for patients. This is a typical response rate for docetaxel in this sort of patient population. This jumped to 20% for patients who got nivolumab. Just to emphasize, response rate means significant shrinkage. So patients who had more than 30% shrinkage in the size of their tumor. Similarly, for patients with non-squamous histology lung cancer, the response rate went from 12% up to 19%. So definitely real differences between those two. And I'm not going to talk a lot about the side effects of these drugs, but in general, the side effects of nivolumab seem less than the side effects of docetaxel. So I'm not going to spend a lot of time on these curves. These are the same data from which I derived the table, but just to show you that I think you guys have all looked at a lot of these curves over time, so certainly so far today. On the y-axis is percent of people who are alive, and on the x-axis is time. And these, this is the green curve is for docetaxel, and the blue curve is for nivolumab, showing that people who got nivolumab tended to live longer. And so one of the things that people get excited about is, and they talk a lot about, is the, quote, tail of the curve. And that's the idea that somehow these immunotherapies are leading to more durable responses for some patients, and that we can, that for that subset of patients, maybe this is something akin to cure, and that's sort of the hype around this. I would point out, though, that there are flat parts of the curve at the end, and this is the tail of the curve that people talk about. But there is a flat part of the curve for docetaxel, and nobody talks about the notion of cure for that group of patients as well. So this is the data for squamous cell lung cancer, improvement in overall survival, and then the same type of curve for progression-free survival, so time until the cancer grows. For the squamous cell population, you see that these curves kind of separate relatively early on, and then this group of people who got nivolumab had a longer progression-free survival than those who got docetaxel. This is the non-squamous data. You can see the curves are a little closer together. I think part of that is just how the data is presented, because there still is a difference in median overall survival of 3 months between these two arms. But it's nonetheless, they do seem closer together, certainly at the beginning. A little bit less emphasis on the tail of the curve here. That's largely because the follow-up time is not quite as long. This is the progression-free survival curve. One thing I wanted to point out is that this is kind of a little funny at the beginning of this progression-free survival curve. You see that, in fact, the chemotherapy arm seemed to be doing a bit better in these early parts as compared to the docetaxel arm. But at the end of treatment and in the statistical terminology, if you integrate the whole curve together, you see that that nivolumab was better than docetaxel. But I think it's a little bit less of a clear difference here on this progression-free survival curve. So one thing that we obviously care a lot about is trying to understand, if you have a drug that works in about 20% of people, can you try to figure out who that 20% is before you treat the patient? And we've had some initial work done to look at that, doing what we call subgroup analyses, basically looking at known characteristics of patients. This is sort of like, you know, things that are just obvious and don't require extra testing beforehand, and things like age, gender, what we call performance status, or how active people are at the start of things, smoking status, as well as EGFR mutation status. And you see that there aren't most people, as you know, the overall population showed benefit for nivolumab. So these little bars, these dots, I guess, with the lines. So the dot represents the center point of the estimate, and then the lines are the confidence about that estimate. And where you see that the overall population derived benefit that was on the left side of the line for nivolumab. People who are younger, left side of the bar. People who are older, still left side. So it didn't really matter. Men and women seem to derive the same sort of benefit. Performance status, so how well people felt when they started, about the same. Smoking status, it kind of breaks off a little bit so that people who were former or current smokers seem to derive benefit, but those people who were never smokers, it was kind of a toss-up. Docetaxel or nivolumab had a very similar outcome. And then relevant for this meeting today, patients with EGFR mutations, the dot is actually on the right side of the line, leaning towards docetaxel. But the fact that this bar is very wide suggests that's not a statement that we can confidently make, and it basically says it's still a toss-up as to whether patients with EGFR mutant lung cancer would benefit more from chemo or for docetaxel. But I think the thing that I take away from that is that it's not a home run, that they definitely are more likely to benefit from nivolumab as well. So we heard a little bit earlier about the use of PDL1 staining to pick patients who are going to get one of these immunotherapies. And that's based on the idea that if this hypothesis is true, that the tumor cell has this interaction with the T cell, then we have to have this molecule, this PDL1 molecule, on the tumor cell for this drug to work. And so these are some of the data from, these are very complicated slides, and I'll try not to dwell on them too much, but these are data about the role of PDL1 expression testing in patients treated with nivolumab. And I would just say that this is various cutoffs of using PDL1, and these are basically all the same. So if you use a cutoff of 1%, 5%, or 10%, it doesn't really predict, among patients with squamous cell lung cancer, it doesn't really predict a group that's going to derive a much greater benefit. That was the squamous cell data. This is the non-squamous cell data, so patients with adenocarcinoma. And this is using a somewhat easier to grasp endpoint, I think, here, and this is response rate. And so this is, so again, in the adeno patient population, this seemed to have a much different predictive power. And so if you look at patients who are greater than 1% expression, so really setting the bar very low, but saying some patients are positive, the response rate with nivolumab was 31%, whereas with docetaxel it was just 12%. So definitely its role as a predictive marker seems stronger here. But importantly, in patients who are negative, the response rate was relatively low at 9%, but not extraordinarily low and not that much different than 15% that we see with patients with docetaxel. If you use different cutoffs, the same idea holds true. So I think my take home on this would be that PDL1 expression may be a useful indicator of response in people with non-squamous lung cancer, but that's by no means something we do in clinic every day today. I don't want to spend a lot of time on this except to say that this drug, pembrolizumab, was approved yesterday with a PDL1 test associated with it. And this graph, there's no data to suggest that pembrolizumab is any better than nivolumab. This is just a graph to show that use of this testing, this PDL1 testing, predicts patients who are more likely to benefit from pembrolizumab. So next I wanted to talk a little bit about one other piece of data. So we talked about PDL1 as one of the one of the better tests for predicting response to immunotherapy. I'm going to talk next about another concept that underlies prediction of response that I think is gathering some excitement, but is nowhere near ready for prime time yet. But it does inform the idea of how these drugs might work for the patient population that we're focused on today. So this derives from work that my colleagues at Memorial did, looking at a relatively small number of patients, 34 patients, who were treated with pembrolizumab. For those 34 patients, they took the tumor and they sequenced all of the exomes in the patient. So that's every coding sequence of DNA in the whole tumor. They found that on average, there were about 200 mutations in these patients. So I want you to keep that number in mind, 200. Then they went to look at which patients got benefit from pembrolizumab and which didn't. I probably should have simplified this graph a little bit because there's too much going on here, but I would point out that, so they had two different cohorts and they're basically the same concept, but let's look at the validation cohort. So DCB was patients who had durable clinical benefit, meaning they were on drug for more than 6 months. They didn't have their cancer grow for 6 months. And the other category is people who had no durable benefit. That is, the drug didn't work for them. And the y-axis here is the number of mutations in the tumor. So you see that people who had more mutations had more benefit. People who had fewer mutations had less benefit. And I mentioned earlier that the average number of mutations for this whole population was about 200. So the average in the group that was going to get benefit was about 240. And the people who had less than that really did not seem to derive as much benefit. That held true both for this concept of durable clinical benefit as well as progression-free survival. So people who had more mutations, the drug worked longer. So how does that apply to us? We don't know so much about the mutation rate in every single subtype. We have the most data for patients with EGFR mutation lung cancer. This is data that was just presented a month ago at our World Congress on Lung Cancer. And this shows the mutation rate for patients with EGFR mutations both before treatment with an EGFR tyrosine kinase inhibitor, drugs like Tarceva and Iressa and afatinib, or after. And you see that the number of mutations goes up over time. So the resistant population has more mutations, but at the beginning it's low. But importantly, this is 100, this is 200. So even the most resistant tumors, or the tumors that are resistant that have the most mutations, they barely hit that 200 mark that I was talking about that predicted the people who are likely to benefit from nivolumab. And then we have a little bit of actual data about patients who were treated as part of clinical trials. And this is from the Nivolumab trial. This is data, again, presented at our World Congress on Lung Cancer last month. This is data on about 30 patients with EGFR mutant lung cancer who were treated with nivolumab. They only had 3 patients who did not receive prior EGFR tyrosine kinase inhibitor, and 2 of those 3 patients did have a response to treatment. But of the patients who had prior EGFR tyrosine kinase inhibitors, the vast majority of them did not respond to nivolumab. And importantly, that 2 out of 3 response rate is exactly what you'd expect to see if patients got erlotinib as well. So I think this suggests to me that immunotherapy is less likely to be a benefit for my patients with EGFR mutant lung cancer, and it's lower on my list of possible treatments. So this is my last slide, summary slide. So choosing patients for immunotherapy. So for nivolumab, there's no clear role for any predictive biomarker, though there's a clear hint that PDL1 staining may be predictive in non-squamous lung cancer. Subset analyses of patients with EGFR mutations treated in randomized trials do not suggest a role for immunotherapy, particularly at acquired resistance to an EGFR TKI. Mutational burden is a leading candidate for a predictive biomarker for immunotherapy in patients with lung cancer, but patients with EGFR and ALK and probably ROS2 are likely to have a low mutational burden. I didn't put a slide in, I meant to describe some of the ongoing efforts that are combining immunotherapy with EGFR inhibitors and ALK inhibitors. And I think it's really important to know that these combinations are happening, but they're happening really in two settings. They're happening in both at the upfront setting, and that's probably the place that's being most commonly studied, as well as the resistance setting. But I think the trials really need to be done, and we need to get a really good sense of the side effects of combining these drugs, as well as whether they work at all in this setting. So I'll close there and look forward to our discussion.